Hello, and welcome to the Sub Internship at IU School of Medicine. I'm Joe Smith. I'm the Internal Medicine Sub Internship Director. In this video, we'll answer the question, why iHuman? So, why iHuman? iHuman is a cloud-based patient encounter simulator that has the ability to train and assess patient care skills, including data collection, interpretation, management, clinical reasoning skills, and written H&P skills. So why did we implement iHuman? Well, some historical perspective is necessary. As you know, we have three sub-internship rotations: family medicine, medicine, and pediatrics. In the past, all three rotations used the NBME advanced exam to assess knowledge at the end of the course. However, in early 2017, the NBME discontinued the pediatric advanced exam. As the school requires all the sub-Is to have a common course structure, we could no longer use the NBME advanced exam in the other two courses. We therefore needed an assessment that was common across all three sub-Is. We considered a replacement test, but the available standardized replacement tests were already being used in the third-year clerkships. Those are the CLIP and MED-U cases. A homegrown test was another consideration, but we found it to be quite resource intensive to create and maintain a homegrown test for such a large class size. You can imagine the number of versions that would be required and the size of the question bank that we would need for such a large class size. We also considered an OSCE. However, Fairbanks Hall is at capacity and has no physical room or resources to take on a monthly OSCE for the sub-I. The resources needed would be intense, and these resources that are available are already utilized. In addition, we were concerned about forcing travel in the center students and for the decreased clinical time that would be available, since we would take 2 days away from the sub-I course for center students in order to complete this OSCE at the end of the rotation. Another concern was cost, both from the standpoint of the resources needed, the standpoint of an addition to Fairbanks Hall or a new simulation center that would need to be built, as well as the concerns for travel and hotel room costs incurred by students traveling from center sites. So the iHuman cloud-based patient encounter assessment became an obvious answer to our need for a common assessment. This would require no travel since it's cloud-based. It would allow us to see your skills that we have listed as course objectives, such as data collection, interpretation, and management, the RHYME framework. It allows a common assessment based on performance on common cases for all students statewide and across the sub-internship rotations. And it's graded centrally, which provides the students with a fair statewide assessment and a reduction in grade inflation. So why do the skills assessed in iHuman matter? This is a process diagram that was created in the Institute of Medicine Improving Diagnosis in Healthcare report from 2015. As you can see, at the beginning, the patient experiences a health problem, then engages the healthcare system, and then we begin to gather information and integrate and interpret that information and create working diagnoses in this cycle of the diagnostic process. This involves clinical history and interviewing, physical exam, diagnostic testing, and referral to other professionals for management recommendations. The whole time we're asking ourselves, has sufficient information been collected? This process, we hope, will result in the communication of a diagnosis to the patient and their family, treatment of the appropriate and accurate diagnosis, and a successful outcome. Unfortunately, we know that diagnostic errors occur. The ones that we will focus on in iHuman are here: failure in information gathering, failure in information integration, and failure in information interpretation, which all can lead to misdiagnosis, delayed diagnosis, and overall poor outcomes. There's a body of literature on diagnostic errors and the importance of data collection and diagnosis. One of the papers is this one from 2014, which read, "Diagnosis remains fundamentally dependent on a personal interaction of a clinician with a patient. The sufficiency of communication between them, the accuracy of the patient's history and physical examination, and the cognitive energy necessary to synthesize a vast array of information." Another paper by Abraham Verghese, titled "The Bedside Evaluation, Ritual and Reason," made this statement: "The recent explosion of imaging and laboratory testing has inverted the diagnostic paradigm. Clinicians often bypass the bedside evaluation for immediate testing." And here you go. This is a part of your everyday life. SOAP, the SOAP note, right? The SOAP note is built by starting with the subjective and objective. If you don't accurately and fully assess the patient's history, past medical history, social history, family history, review systems, exam, data, and imaging, you cannot possibly come up with an accurate diagnosis or an accurate differential diagnosis. These steps, subjective and objective, are so key to coming out with an appropriate differential diagnosis and having a reasonable chance of finding the right diagnosis and therefore treating the right diagnosis. I'd like you to watch these next two videos, as they will highlight the importance of the diagnostic process.
The day started really early when, out of the blue, I had this pain down my left arm. I remember reading or hearing something about pain in your arm could be a heart attack. I decided I better get myself checked out in the emergency room. The medical staff in the ER snapped to attention. I explained my symptoms. Immediately, they ordered the standard cardiac tests. All of my tests came back normal. The doctor said to me quite clearly, "You are in the right demographic for acid reflux." My first reaction was embarrassment that I had just wasted 5 hours of their very valuable time. But even I knew that pain down your left arm is not a sign of indigestion. And I'd asked the doctor about that. The nurse in the ER warned me quite sternly that I should stop asking questions of the doctor. She said he was a very good doctor and he does not like to be questioned. And so I was sent home from the ER in the middle of a heart attack. Over the next 2 weeks, my symptoms continued, and I didn't want to go back to the emergency room and be embarrassed again. I thought the kind of care that I might get would be affected if they saw me as a difficult patient. But I knew something was terribly wrong. The second time that I arrived at the ER, I had an emergency procedure to unblock a 95% blockage of my heart. Since my heart attack, I have ongoing cardiac issues. I had to stop working. Had I been diagnosed correctly the first visit, my outcomes would have been far better than they turned out to be.
My son Cal entered the world about 2.5 weeks early. To hold your first child, your firstborn, is really it's very powerful. But the first day they noticed that he was turning yellow. We were told that he was jaundice and not to worry about it. We were discharged with a well baby. 3-hour naps went to 4-hour naps, and then they went to 5-hour naps. He was still yellow, he was getting kind of floppy. My husband and I took Cal to the pediatrician, and whenever I brought up a concern, a worry, or a symptom, I was always told that I was overreacting. He didn't get better. So when we took him to the hospital, a resident actually admitted Cal, and he documented that Cal's blood type was the same as mine. Actually, Cal's blood type was A, and I was O. So that document error had a significant impact on how they were treating Cal. Cal's bilirubin was the highest level they'd ever seen in the hospital. This toxin was building up in Cal's bloodstream. His legs were trembling. He would stop breathing when he was sleeping. He couldn't breastfeed at all. We were really told not to worry, babies do funny things. I was reporting very classic symptoms of the onset of brain damage with jaundice. Nobody took me seriously. 16 months later, he was finally diagnosed by a clinical team in another state. The MRI clearly indicated they had suffered brain damage from his newborn jaundice. Cal is now 20. He has significant cerebral palsy. He can walk independently with a walker. His speech is very impaired. He's a smart brain trapped in a body that doesn't work.
The first time I felt anything different was in the car ride on the way home from work that day. I felt like I got hit in the chest with a sledgehammer. When I walked into the ER, I presented myself as having a heart attack, and they immediately took me back in. The emergency room doctor had come in and did the initial diagnosis of a heart attack. My wife arrived at the hospital 15, 20 minutes after I arrived. She was the first one other than myself to notice that my leg was swelling and that my foot had started to go prone. And that caused them to further investigate what was happening. In a matter of minutes, I was being operated on. They had diagnosed me with a AAA aortic dissection. That's when the inner layer of the aorta disconnects from the outer layer and restricts blood flow. With this condition, very few people walk away. Very, very few. The critical thing that the medical staff did was listen. Even though the initial diagnosis was a heart attack, we didn't take that as the final word. My recovery has been a fascinating journey. Some days are better than others, but it's great to be alive. I'm very thankful that the diagnostic team and the surgical team were working hand in hand with each other through the whole process. I'm looking forward to retirement and enjoying my family and my grandkids, which I wouldn't have that opportunity if we hadn't spoke out. One of the things that I've learned through this experience is that no diagnosis is complete until it's complete.
You know your body. You know when something's not right.
That teamwork, though, it's something that we all need to strive for, because I believe you will have better outcomes, you will have better communication, just overall better care.
The communication is the key.
These videos by the National Academy of Sciences, formerly the Institute of Medicine, provide some examples of the importance of diagnostic accuracy and collecting all the necessary information, listening to your patients and their families. All of your faculty almost assuredly can give you examples in their own practice and their own training of diagnostic errors and the adverse outcomes that occurred in their patients. This statement comes from the Institute of Medicine 2015 report, Improving Diagnosis in Healthcare. The best estimates indicate that all of us, meaning you, me, your family, will likely experience a meaningful, meaning morbid or mortal, diagnostic error in our lifetime. A diagnostic error is the failure to establish an accurate and timely explanation of the patient's health problems or communicate that explanation to the patient. The data that we have on diagnostic errors is extensive and quite scary. This is just a small portion of the available data, which showed that 40,000 to 80,000 U.S. hospital deaths annually occur due to diagnostic errors. And 6 to 17% of all adverse events in the hospital are due to diagnostic errors. In studies of malpractice data, they have found that the leading type of paid malpractice claim is diagnostic error-related malpractice at 28%. It's also responsible for the highest proportion of total malpractice payments. And diagnostic errors are twice as likely to result in patient death than other types of errors. The mean payout per diagnostic error claim is almost $400,000. This study from Gandhi in Annals of Internal Medicine from 2006 did a retrospective review of 307 malpractice claims that were known to be due to missed or delayed diagnoses in the ambulatory setting. 181 of the claims was associated with an adverse outcome. 30% of these adverse outcomes were death. The top diagnosis associated with a missed or delayed diagnosis and a subsequent adverse outcome was cancer at 59%, with fracture and MI coming in at 4% apiece. The mean delay in diagnosis from the initial missed or delayed diagnosis, the diagnostic error, was 465 days, over a year. When they analyzed where the breakdown in the diagnostic process occurred, 55% were due to a failure to order an appropriate diagnostic test. 42% were due to a failure to obtain an adequate history or perform an adequate exam. And 37% were due to incorrect interpretation of a diagnostic test. So why iHuman? I want to assess whether you have obtained the tools required to be a successful diagnostician from the IU School of Medicine. And I want to offer you feedback towards improvement in those skills. I want you to be the best diagnostician possible. My motto in patient care is do for your patient what you would do if they were your immediate family member. That means you want to be the best you can be all the time when you're taking care of patients. I want to give you the tools to be a great diagnostician. Thanks for listening, and we'll move on to the next video in just a moment.